Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about mixed connective tissue disease. It is also called as overlap syndrome or sharp syndrome, and this is a condition that is characterized by the occurrence of symptoms of various connective tissue diseases in a single patient. As a result of this, various combinations of CTDs occur, and the CTDs that are commonly seen include systemic sclerosis, SLE, dermatomyositis, polymyositis, and rheumatoid arthritis. In any given patient, almost always clinical features of systemic sclerosis are present. And these patients, they have high titers of anti-U1 RNP antibodies. Coming to epidemiology, most commonly females are affected. The female is to male ratio is 9:1, and the age at onset is usually in the second to third decade. Coming to pathophysiology, it is not clear. There is some genetic predisposition and role played by HLA, DR4, DR1, DR2, even MHC class 2, class 1, and also certain infections such as viral infections such as CMV and EBV. They have a role in that they kind of have molecular mimicry, where they mimic the molecules of host tissues, and as a result of which the antibodies formed end up destroying the host tissues. And in some cases there can be vitamin D deficiency. In some cases UV radiation also precipitates the lupus elements of mixed connective tissue disease. And also there's immune complexes found in these cases with reduced T cells with normal complement levels. So ultimately all these triggers, they cause an immune response to U1 RNP in the host, and these patients, they also have high titer of antibodies to extractable nuclear antigen. Coming to clinical features, so it depends on the type of combinations of connective tissue diseases. Therefore, many clinical variants can be present. So the presenting symptoms are usually Raynaud's phenomenon, arthralgia or arthritis, sausage digits, and swelling of dots of hands and feet, that is sclerodactyly. So Raynaud's phenomenon, it is often an early manifestation, and it can present as ice-peak digital infarcts or as gangrenous digits. Sclerodermatous changes. These include calcinosis cutis, sclerodactyly, and periangual telangiectasias. And DM-specific dermatomyositis specific changes such as heliotrope rash or even Gottron papules are usually not seen. Poikilodermatous rash-like areas can be seen on upper trunk and proximal extremities. Arthralgias and polyarticular arthritis, which can be mild to erosive, is seen in about 50 to 70% of cases. And other manifestations include livedo reticularis, livedoid vasculitis, cutaneous small vessel vasculitis, pustular leukocytoclastic vasculitis, cutaneous mucinosis, rheumatoid nodules, and urogenital mucosal lesions. Coming to complications, pulmonary hypertension is the most serious complication of MCTD, and it is associated with majority of deaths, and it is also associated with antiphospholipid antibody syndrome. And pulmonary fibrosis, pleurisy and pericarditis, esophageal dysmotility causing reflux esophagitis and dysphagia, thrombocytopenia and thrombotic thrombocytopenic purpura, peripheral gangrene are all some of the complications. In addition to pulmonary hypertension, other causes of death include nephritis, myocarditis, and widespread vasculitis. Coming to investigations, serology. So in all these patients, anti-U1 RNP is positive and anti-ENA is present, is positive and is in high titers. Anti-Rho, anti-La antibodies indicate Zika syndrome being involved, that is Sjogren's syndrome. Anti-PM1, anti-Q antibodies indicate polymyositis and systemic sclerosis overlap. Anti-SLK antibodies indicate SLE, systemic sclerosis, and Zika overlap. And anti-endothelial antibodies are present in about 50% of the cases, whereas anti-dsDNA antibodies are rare, but they can be present in low titers and they usually disappear on management. And the complement levels are normal. Coming to investigations for lungs, pulmonary function test, chest X-ray, high resolution CT scan. For heart, echo, renal function tests, assessment of esophageal motility, and biopsy of the skin lesions, which usually shows keratinocyte necrosis, lichenoid interface dermatitis, and vascular thrombosis. And direct immunofluorescence of normal skin, it shows a speckled epidermal nuclear staining pattern, and Neelfold capillaroscopy ought to be done. Coming to management, the goal is to control the symptoms and also to maintain the function of the organ and to prevent worsening. So organ targeted therapy is to be given. So in the first line, For LE-like lesions, we go for topical corticosteroids along with sun protection. And for Raynaud's phenomenon, we go for vasodilators like PDE5 inhibitors or even endothelin receptor antagonists. And systemic corticosteroids ought to be started early at a dosage of 0.5 mg per kg body weight with rapid dose reduction. Coming to second line management, hydroxychloroquine is to be given for LE-like lesions. And for severe systemic disease, we go for other immunosuppressants or immunomodulators like methotrexate, cyclosporin, azathioprine, mycophenolate mofetil and cyclophosphamide. Plasmapheresis and autologous hematopoietic stem cell transplantation all can be tried. Thank you. Subscribe for more.